Thank you very much, Professor Apple, for this elegant presentation. And now I have the pleasure to introduce Professor Joseph Glgarov, and his talk will be about the critical review of commercially proposed HGS tests, drawing the plan for the future. Professor Glgarov is a professor of medical oncology, Tenon Hospital, President of Rome, France.
Thank you very much. Thanks a lot for the invitation. Again, thanks particularly to Isham for his friendship and to all our colleagues from Egypt and all the Arabic countries. So you asked me to speak about the commercially available NGS test in breast cancer and to know exactly what is the place of this kind of test, I think, in everyday practice. So what I will want to begin with is what about the concept and the expectation of what we call the precision medicine? And I will go to very basic definition that you probably already know, but just to remind us what is a pure prognostic test or parameter. And you have here clearly, this is from the Dan Hayes presentation and book, looking at two different tests and showing that if they are purely prognostic, they will not change the outcome of the patient regarding the treatment that you will apply, because as you see here, the relative benefit is equal, but you will just define two populations of different outcomes with or without treatment, without clear influence of the treatment. But what we expect and want in everyday practice is more predictive parameters that will help us. Prognostic parameters help us for the definition and stratification of the patient that we are to treat, particularly in clinical trials, but predictive factors help us to choose exactly the type of the treatment we want to apply to a specific situation. And one of the most important predictive parameters that we're using since now more than 20 years, or close to 20 years, is HER2. And the next step was at the same period of time the genomic revolution. And you can see just here several titles of scientific or non-scientific review, just focusing on the fact that with the new molecular tools we have, we probably in the future will have more possibilities to identify better what are the potential prognostic and we hope predictive parameters. And I will just go through 2 or 3 examples of the 2 last, from my point of view, very important prognostic and potentially predictive parameters. The first one is the ESR1 mutation. And as you know, the mutation of the estrogen receptor 1 receptor is a prognostic parameter, as you see here in the Bolero-2 clinical trial, but also is associated with different outcomes regarding when you are applying the treatment, and particularly showing that maybe the population with this kind of mutation might benefit more from several treatments like SERDs or potentially targeted treatment in combination with endocrine treatment. This is for also the fulvestrant as it was published in the GCO 2 years from now. And the second one, and was already mentioned before, the PIK3CA mutation, particularly in estrogen receptor positive population, that are associated with the outcome, but also the possibility of target to this mutation with new generation compounds, and this was already published and presented several times, and we are expecting actually the next generation trials that we hope will help our patient to have more benefit with these new compounds. And you see in the publication of the BEL-2 trial that when you use this kind of compound in the overall population, particularly in the wild-type population, the benefit do not appear, but when you focus on the PIK3CA mutated population on the right side, you might find that this is a predictive factor for the outcome of the patient when you are using the PIK3CA, the PIK3 inhibitors. So my first step conclusion is that actually we have some validated relevant prognostic and predictive molecular parameters in breast cancer with clinical utility. In the adjuvant setting, I will not focus on, and particularly I will not go through the molecular signatures. We can discuss if you want. But my personal point of view is that a lot of them are prognostic. We have maybe just one that is predictive regarding the result from the oncotype DX, but we need a prospective validation. And in the metastatic setting, we're using the estrogen receptor, progesterone, HER2, and potentially in the future, the ESR1 mutation and the PIK3CA mutation. The second step is, since we know that we have this possibility to better identify some molecular abnormalities in the tumor, what is the NGS experience in breast cancer in the clinical trials, and do we have any signal regarding the potential clinical utility? And I will go through two French trials that were one of the very first trials publishing the results. The first one is a trial published by Professor André from Institut Gustave Roussy, the SAPPHIRE-1 trial. This trial, as you see here, enrolled more than 400, close to 500 patients in the trial. And the endpoint of the trial was to address the question of the possibility to provide a biopsy, to have the NGS, and potentially in the next step to see if you can orientate this patient to a specific clinical trial and then see the results. And on the right side, that you can see in the very first publication, which is really interesting, is the percentage of type of distribution of targetable genomic alteration. Interestingly, in the very first publication, ESR1 mutation was not identified. Because again, if you do not know what you want to find, you will probably have an amount of information that you will not look at. And then in the next presentation, 2 years after, they have published and presented the result that they have also found close to 15% of ESR1 mutation, particularly in pre-exposed patients to endocrine treatment in metastatic setting. But however, the most important information here for me from a clinical point of view was, if you look at the end, from the 470 patients that were enrolled in the trial, even if close to 300 received, had a biopsy, and had a NGS sequencing, you see that only 55 patients received clearly targeted therapy in a clinical trial. And the results are here. It's close to 30% of just clinical benefit rate, including stable disease and some responses. That means that the correlation between this approach and the clinical utility is not yet for routine according to the first trial. The second one was the Shiva trial, presented also several times and published, and the Shiva trial addresses the question in everyday practice. You use this approach and you will then randomize the patient between one, treatment of physician choice, or potentially if you have identified some targetable abnormalities using the NGS, you can potentially use targeted treatment even if they are not actually registered in the field of the breast cancer treatment. And you have on the right side the different type of abnormality that the colleagues have found. This was published by Christophe Le Tourneau from Institut Curie. And the results are here. If you just look at the median PFS, it's 2 months. And no difference between the targeted approach using the sequencing comparing to the treatment of physician choice. Again, the level of evidence that it works is a little bit low, and even very low. So the conclusion here, and if we look at all the results we have since the last year, and you have in this table the different genomic alteration that might be targetable in everyday practice. On the top, HER2 and BRCA mutation, HER2 amplification and BRCA mutation, which is very clearly in correlation with positive results from clinical trials. Then we have some very potential interesting results. The first one is the anti-archaic translocation. We have very interesting result presented at the ASCO meeting last year, showing that this kind of translocation might be targetable with very good results in the majority of the patients that have this kind of translocation. But just a few patients with breast cancer were included in this phase 1 trial. The PIK3CA, the EKT, the estrogen receptor 1 mutation, and also potentially some HER2 mutation. But you have also on the second column the incidence, which is very low. And then you have several ones that are actually, some of them, under investigation regarding the clinical trials, or potentially even without any clinical evidence that we have possibility to target, or potentially any signal that it works even in a phase 1 trial. So at the end, regarding the second step is, yes, we might have a lot of information, but comparing to the clinical way we are treating the patient, out of the big driver that we have, HER2, estrogen receptors, and BRCA mutations, we have to be very careful regarding using these tests. So now the last point, utility and challenges of commercially available NGS tests. And first I will begin with several considerations. The first one, and this was published pretty recently last year, when you compare the rate of mutation in the metastatic setting, the red boxes, comparing to what are the rate of mutation in the primary tumor, the blue boxes from the TCGA database, you can see that you have different kind of tumors. And if you look at the breast cancer, that I've put the first spot that I've showed to you, you can see that there is a huge difference between the rate of mutation between the primary tumor and the metastatic sites. If you look at the ovarian cancer, it's pretty stable. That means that if you look now at an information from the NGS, from the primary tumor or from the metastatic site, you will probably not have the same information for breast cancer, but maybe you will have it for the ovarian one. The second point is that even some of the new mutant clones make potentially high clinical difference and treatment impact. And this is just to show you, that was published in Clinical Cancer Research now more than 3 years before, regarding the rate of estrogen receptor 1 mutation between the primary tumor and the metastatic site. There is a huge difference with close to 20% of mutation rate in the metastatic site and less than 5% in the primary tumor. That means that if you do not do the biopsy on the good metastatic site, probably that the information you will get might be not relevant. The third point is that the mutational landscape of breast cancer is pretty complex. And when you look at the recent publication a few years before regarding 100 breast cancer genome analyzed, it was presented by George Slage at the ABC4, you can see that some of them have even close to more than 5 or 6 drivers mutation. And we have never used nowadays the combination of 6 targeted treatment for 6 potentially driver mutations. So that means that even if we have this information, even if they are targetable from a pharmacological point of view, it will be very difficult to combine these kind of approaches. So what about now the NGS, commercial NGS? And the term of commercial is very important because this is a commercial fight. So it's not because you can have it and you can buy it that maybe you have to do it. Just to show you what you have, the panel of genes that you have actually in the Foundation One medicine testing, as you see here, very interesting, but very few of them are really relevant in breast cancer. The other one is the NCMH treatment arm, and the targets you see on the right side. It might be interesting for selecting patients to potentially address them in clinical trials, but in everyday practice, what do we have? We have the first thing, difference between the tests. And you see that if you're comparing one test to another one, it could be that you will not find exactly the same information. Does it mean that the two tests are really different and the information are not relevant? To be honest, nobody knows. But that means that we have to be careful using all these tests routinely without addressing the good question. The second thing is the difficulty of drug access. Even if you find a very interesting potential driver mutation, this was published in GCO in 2015, when you look at 2,000 patients that have underwent genomic testing, there was only 83 of them that do access a specific trial or potentially relevant trial. So that means that the vast majority of the patients that you will have will probably not benefit from the result. And you have to be aware about that. And finally, even if you use these kind of drugs, and this was published pretty recently at the end of the year in the British Journal of Cancer, in British Medical Journal, sorry, the availability of evidence of benefit regarding this kind of drugs, when you see the evolution of the new targeted drugs that have been registered in Europe, on the right side, you can see that we have a very, very late data totally on the right side regarding the quality of life and the overall survival benefit. And in fact, there is only 1/3 of EMA-approved cancer indications that were associated with survival benefit in phase 3 trials. The median survival benefit, when you look at all these drugs, is close to 2.7 months, and the significant quality of life improvement is only reported in 10% of the approvals. That doesn't mean that we don't need to go further and test this drug and test the new drugs, but that means that we have to be careful when we have just a result saying that it's possible to use a drug even if we have no data regarding the clinical utility of this approach in everyday practice. And last but not least, this is the evolution of the extra cost for diagnosis and off-label use of expensive targeted drugs that we have when you're using routinely, I will say, NGS without putting patient in clinical trials. This is the potential evolution that you will have. So be careful. So drug registered according to global genomic predictor of sensitivity might be interesting. And this is another point. All these tests will give you a very important information regarding the new approaches with the immune therapy. And I have to remind you that actually pembrolizumab was approved according in metastatic cancers, not specifying the type of cancer, according to the presence of microsatellite instability or mismatch repair deficiency in all solid tumors. You can find this kind of information potentially in this NGS test, but you can also find it in another way with your pathologist, with other approaches potentially. And the second one is that the future might be that the mutational load is considered a strong predictor of immunotherapy approaches. This kind of test could also give you this mutational load, but maybe we will have also other approaches that are interesting. So my conclusion is this way. Precision medicine is a real new tool. Clearly, we have a new tool. As every new tool, we first need to better understand how to use it. Then before using it, we need to know what treatment might be possible to offer to the patient. And finally, what are the expected results? And we'll just finish with this cartoon. You see this guy and you see the doctor. I'm afraid that we will not be like this doctor in a few years, giving just a result regarding the type of mutation we have, but at the end of the day, without knowing exactly what we have to do with and how to treat the patient. Thank you.